Well, good morning, everybody, and thank you for hanging in here with us. If you think the regulatory world and guidelines is controversial and complicated, wait till you hear about legislation at the state and federal level. Clearly, we're living in a world in which technology, virtual care, all the peripherals and diagnostic tools, access to high-speed broadband are moving at the speed of light. And legislation at the state and especially at the federal level is moving probably at a snail's pace to try to catch up. And so what happens is we have this sense of paralysis of what do we do, how do we keep up? A lot of concerns have been raised about the cost of telehealth. We heard some panelists talked about the fact that, well, maybe we shouldn't be saying that it saves money. Well, I always go to the perspective that we should be thinking about telehealth in the context as a mode of improving the quality of health. It's just another way of doing it. And to the extent that it adds value, then we should consider adopting laws that can help move it forward. We do this in the context of the triple aim of healthcare. I think if anything came out of the last 8 years of the Obama administration and reforms in CMMI and CMS have been the notion that we're moving toward improving the value, improving health outcomes, moving away from a system of fee-for-service to the extent that every time we do a particular procedure that it's another bill. And I think that's been one of the biggest obstacles for telehealth, that the policymakers goes immediately to the notion that, oh, if we expand the units of service or the billing codes, we're just going to have to pay more money. Not thinking about the cost avoidance that could occur, the convenience to the patient, how the health system is being transformed to put the patient, the consumer, at the center of the healthcare system to increase the efficiency and the quality and the convenience to the patient and the provider and to the health system, and also to for the payer. So today we're going to be talking about both state and federal policy, and our center has been funded by the Office of the Advancement of Telehealth, along with MATRC, to be the National Telehealth Policy Resource Center. We, along with our national colleagues in Alaska, which is the National Technology Assessment, you may have heard this morning from Garrett, one of our colleagues. We're there to provide objective information. We don't receive money from vendors. We don't have any paid advertising on our website or on our procedures. We're here to be providing the best quality information on a timely basis related to state and federal policy and regulations. And if you visit our website at the Center for Connected Health Policy, CCHPCA, you'll see that we have an interactive map. We keep track of every state's laws and regulations according to 10 different categories, including definition, what gets reimbursed, what doesn't, e-prescribing, other areas of interest related to policy. And and I did a quick survey of the states represented by MATRC, and it's really interesting to see that West Virginia, Delaware, Pennsylvania, Maryland, Kentucky, North Carolina, New Jersey, DC, only reimbursed for live video. As far as I could tell in my quick review, no reimbursement for store and forward, which is a very efficient way of providing care, particularly around ophthalmology and around dermatology, and no reimbursement for remote patient monitoring, which is going to be increasingly important as with our aging population, with your Medicaid programs. That doesn't govern what commercial payers do. And also in terms of we'll be hearing more from one of our panelists related to the Federation of State Medical Boards and their compact. Only one state that I could see of the states have actually joined the compact. That would be West Virginia. So we have a long ways to go in MATRC in terms of catching up with other states in the country, states like Minnesota, Hawaii, California, even Mississippi that have very progressive laws related to the use of telehealth. So today what we're going to be focusing on is both state and federal policy. We have two outstanding panelists, good friends and colleagues in this world of telehealth. Nathaniel Lacktman is a partner in Foley and Lardner. Nate is one of the, I think, country's experts related to telehealth regulations and policies, particularly at the state level, and the nitty-gritty of what goes into regulating the laws, because states, as you know, have great flexibility. The federal government pretty much oversees Medicare, and Medicaid is administered by the state, and the states have the ability to develop their own laws related to that. And so he'll be focusing on that. And then my good friend Alan Morgan, who's the CEO of the National Rural Health Association. Alan's been there since 2003, I believe, and has been a passionate advocate for rural people and rural communities. And we'll talk primarily from the federal perspective, but also understanding the fact that telehealth, especially in rural communities, makes such a big difference when there are shortages of providers and services. Again, we're living in these crazy political times when, and it's just not this election, it's been in past elections when whoever gets elected recognizes that the reason that they got elected is that rural people came out and voted for them and put them over the top. And so we sit back and wait to see, okay, there's all this sensitivity now. What can we do for rural communities? And we haven't seen that much happen. And I think under Obamacare, there were some real shortcomings. And we'll see what happens over the next 4 to 8 years related to national policy. So with that, I'd like to invite Nate to come up and give us a perspective on from the state policy and regulatory perspective. Thank you.
Oh, great. Can I use this?
Yeah.
Okay. Thanks, Mario. Good morning. It's my pleasure to be here. I spoke last year at the MATRC conference, and it was a lot of fun, and so I'm really happy to be back again. Where do we go from here is the topic of the session today overall, and my section is Future Trends in Telehealth and State Law. I am a partner at Foley & Lardner, healthcare business lawyer. I chair our telemedicine practice across the country. We have about 100 healthcare lawyers, 1,000 lawyers overall, and 10 lawyers dedicated in our telemedicine practice. I've been doing it practicing law for 13 years and involved in telemedicine for a bit over 7. I'm really proud of what we've built, and I'm really proud to kind of share information with as many providers as possible. Lawyers are in the information business, right? Strategic advice, and some of them really hold that close to their chest. I don't think information should be held captive, so I write a lot, I speak a lot, I have tons of handouts. Even though we didn't have slides, I couldn't help it. I was like, okay, Kathy, we have to have at least a handout. So you can look there for a handout all about controlled substance prescribing, tools you can take home and use in your own practice. And speaking of information, a little plug for Dr. Rubin and Dr. Krupinski's book on telehealth coming out. I did the legal chapter. It was my pleasure. It's going to be a great resource for any of you. This morning, I'm going to talk about the 4 Ps, and no, it will not be as randy as the ventriloquist or this lunch speaker last night. I'm going to talk about payment, practice, prescribing, and patience. And when I say patience, I don't mean a patient. I mean having patience. First topic is payment. Right now, 31 states plus the District of Columbia have so-called telehealth coverage laws. Coverage laws mean that a health plan must pay or reimburse a provider for a service delivered via telehealth to the same extent that that payer would reimburse a service if delivered in person, right? So what it does, some people refer to it as a mandate, typically lobbyists on behalf of payers. I think it's more appropriately characterized as a consumer rights issue because the individual consumer, you and I, we purchase healthcare insurance. It's a contract between me and the health plan under which I pay a premium every month. In exchange, they say, Nate, I will take care of your health care needs, a suite of services. And I believe it's arbitrary for the health plan to tell me, no, you have to get that service in person. You do not have the option to get it via telehealth, even though, right, everybody in this room can attest to the clinical efficacy and safety of telehealth, and even though the parent company of that same health plan might offer telehealth coverage in different states when they're required to it, but simply because I live in Florida, they don't give it to me. There is no rational justification, and as a consumer, individual purchaser of insurance, I feel particularly disenfranchised. I do not have the ability to speak with my dollar like I do when purchasing auto insurance or life insurance or any other form of insurance available on the market. So we're seeing a trend. However, there are gaps and shortages, and Mario has spoken on this very eloquently before, in the coverage laws. They're basically outs, exit doors, and opportunities for plans to not cover telehealth in a broad, meaningful way due to softness in the legislative language of the statute. That creates confusion and frustration. I see it on your faces. I hear it at conferences all the time. It's the reason why people raise their hand and ask questions about, well, if I'm at the distance site, it's a non-covered service, what are the originating site, the facility fee, and what's this GT modifier, and why is there a 95 modifier now by the AMA, right? It's all the result of confusion and a lack of homogeneity in the process. That's changing. More states are passing coverage laws, and they are using model language to do so, now being aware of how the private market actually reacts to poorly drafted statutes. Furthermore, some states that were early adopters or passing these laws are now revisiting them, realizing, you know what, maybe we messed up, or maybe we need to revisit that. Maryland is a great example of a state that could do to revisit it. Today, actually, the Maryland Senate is having a hearing on Bill 983, which would basically add substance abuse counseling services to the telehealth. What it doesn't do, though, is fix the overall language of your telehealth statute. So I think some advocacy and cooperation would be good. We're also seeing narrow networking more in telehealth, right? And that's a concept that health plans have used outside of telehealth space, but they'll say this is our exclusive provider. Right? Our members have access to a telehealth service direct to consumer, but if you're a hospital, medical group, you may be in network, you can't deliver services to members via telehealth. That's kind of unfair, wouldn't you say? No? Of course you should say it's unfair, right? There are certain economies of scale that can be gained with health plans and those kind of relationships, but it doesn't open the opportunity to physicians at broad. I do see trends, though, in working with clients that we negotiate one-offs under the participation agreement. We'll say, let's do this for a year between us, and we'll add the modifier, we'll track utilization and cost and whatnot, and if you don't like it, plan, then terminate it after a year. Most participation agreements, if you didn't know this, allow the plan to terminate without cause on a 30 or 60-day notice anyhow. So it's really not a big commitment on the plan's part. You should absolutely explore that. There's a Colorado bill pending that addresses this narrow networking or concepts of any willing provider. Finally, we're seeing an increased sophistication in employer arrangements as well because they want to drive utilization. Employers are not satisfied with paying an administrative access fee plus a per encounter fee, having very little to no utilization among their employees. It's great, but then there's no buy-in. So what they're trying to do is find ways to lower the employee copay because the research has shown that if the closer the employee's copay gets to zero, their utilization will go up to 30%, and that's a win-win for everybody involved. That can help with long-term cost savings or care diversion. But then there's the intersection of employers that have high deductible health plans with HSA and tax implications. So we've worked to analyze the employee benefits and tax aspects to navigate these rules and find solutions and pathways so you can deploy your telehealth services in a meaningful manner. Number two, practice. On the practice side, in-person exams requirements are going away. Originating sites are going away. Telehealth consent is going away. I think Oklahoma said this is silly, let's just eliminate it. The modality, audio, video versus store and forward versus interactive audio, that's being expanded. Some rules, DC has some proposed rules that came out a couple months ago. There's also other attendant rules that have been obstacles for telehealth which are going away. West Virginia has who's West Virginians, raise your hand. I know I met one guy yesterday. Oh, right there. CON process, and I believe like in 2015 it gave UPMC some trouble offering telehealth services into the state, and like they had to do a CON, and I think it was denied. There's a proposed bill to eliminate West Virginia's CON. Florida has the same bill concept pending. Licensure, FSMB, 18 states are locked in with another 8 pending. I don't think that the promise of the FSMB compact is quite as seamless as we wanted it to be. At the end of the day, it was not like the nurse licensure compact, but it is an opportunity. There's also a number of states that we update and track this all the time on the various rules, but peer-to-peer consultation exception, they're being more cognizant of how that applies in the telehealth space. And that's great because you can use that for destination medicine programs, online specialty consults across the country where patients can access your expertise, and then if they like it, they'll travel for in-person treatment. It can be a real revenue generator and a way to spread the expertise of your hospital or system. The third P is prescribing. I think we're also seeing a reduction of states that mandate an in-person exam prior to issuing a prescription. That's tied with pharmacy board rules as well, which define a valid doctor-patient relationship. And controlled substances. Raise your hands if you're involved in prescribing controlled substances in any manner. Okay, telepsychiatry, endocrinology, medical weight loss. There's a number that use a lot of it, and those rules are also becoming more flexible. Virginia in February passed a law saying, yeah, now you can prescribe via telemedicine controlled substances. West Virginia, they also, I think, have a pending bill to change it, or it might have been signed. It used to be you couldn't prescribe Schedule II. Now you can prescribe any schedule as long as it's not a narcotic. And you're like, well, what the heck is a narcotic under the definition of the statute? Well, that's actually, drugs are all categorized, narcotic or non, by DEA, and assuming West Virginia utilizes the DEA schedule, which I think it does, there's a list. So you can email me, I'll send it to you. DEA updates it, or just go to my Twitter feed. And earlier yesterday, I put a link directly to it, so you can find that as well. And the Ryan-Haight Act itself, that's a federal law regulating controlled substance prescribing via telemedicine. The handout discusses that, and I wrote an article yesterday that you can have it, take a look at, and explains it. But the good news is their DEA has announced that they're going to issue a proposed rule coming out this year to create a special registration for telemedicine, which would basically be a little asterisk on your DEA registration number and allow you to prescribe via telemedicine without an in-person exam. So that's really great. Finally, the last P is patience. I see around here everybody looking for the next big thing. The eyes glaze over when we talk about direct-to-consumer or just low acuity triage care. And there's this relentless desire for the next new big thing, AI, I want asynchronous or whatnot. You are in the vanguard right now of healthcare delivery, and other people are swimming in your wake. Okay, I know you feel a lot of pressure for ROI, you want to have scalability, you want to have big news, you want to be in the press, right? Why are we feeling this? I think it's due largely to what I call the democratization of healthcare. The technology is so cheap, and there's so much venture capital invested in this, and new companies popping up all the time. And that changes the atmosphere of healthcare. That creates a rapidity, rapidness, a desire. I mean, I could create the architecture and all the legal documents you would need for a direct-to-consumer telemedicine company over a weekend, okay? And I could purchase the technology from a platform vendor as cheap as a couple $100 a month. Now, I don't have the marketing staff. I could hire an SEO firm. I don't have the physicians, but I could go on Craigslist and contract with them in 1099s. And by the end of a month, I could have my own company. Do I have any business practicing medicine? Probably not, okay? But that is the reality of what's going on. And you have one little interesting idea. You get a couple $1 million. And then I imagine everybody in this room hears about it and feels threatened or uncomfortable in such a way. Why have I been working so hard on my service line and I'm not getting that kind of exposure? We're not getting the kind of patient volume. Please be aware that so many of these press releases, perception is not necessarily reality. And there is an inherent tension between hospitals and universities and doctors, who are the traditional gatekeepers of medicine, and then and laid the groundwork in this new wave of entrepreneurs in digital health. Some of the established guard feels that this new wave might be a threat. Or startups because they're drinking from wells they did not dig. They're warming themselves by fires they did not build. And that's okay because in part that is the nature of progress, which would be maybe the fifth P here. So we should thank and embrace all of the academic medicine professionals who have, for the last 20 plus, 30 plus years, worked to bring telemedicine to where we are today. And we should also embrace the innovation that we're seeing from all these professionals who are standing on their shoulders to bring telemedicine to where we want to be. But be patient. You are so far in advance of where your patient consumer base is and all the laws and all the rules are following in your direction, the payment reimbursement rules are going in your direction, that you should feel incredibly confident that there is a pathway for the next 5, 10 plus years, that what you're doing now will give longevity for your service organization, for your industry, and for your own career. So please do keep that in mind as we take a look at these state laws and try not to embrace the frustration aspect, but the positivity aspect of what we're seeing in these trends. Thanks.
Good morning, everyone. How you doing?
There's Ellen.
Good. Yesterday afternoon, I was at a meeting on federally funded research, and I introduced myself as Alan Morgan, CEO of the National Rural Health Association. And one of the participants said, "You're the head of the World Health Organization?" I said, no, rural, not world. NRHA, not WHO. And her reaction was, oh. It is so nice to be here at a telehealth meeting where you appreciate the role, the value, the responsibility of rural health. I've been asked to talk about what's happening in rural health right now as it relates to telehealth, and touch on the legislation that's going through Congress right now of particular relevance. If you are still in your seats at this time of the conference, chances are fairly good you're attuned to what's happening in Capitol Hill. But I do want to mention a couple issues on this. Last year, in last Congress, we saw the introduction of the Connect to Health Act, which held great promise for where we could go from telehealth, and also how would that impact on rural health policy as well, too? It would include telehealth within the Medicare Advantage program and remove a lot of barriers that we currently see. Just last week, we saw in the Senate the introduction of the Telehealth Innovation and Improvement Act. Again, this legislation would hope to break down those barriers that we're currently seeing by requiring CMMI, Center for Medicare and Medicaid Innovation, to test the effect of inclusion of telehealth in any healthcare reform proposal going ahead. I'm hopeful and optimistic in the very near future we'll see the reintroduction of the Save Rural Hospitals Act, which actually creates a new provider type in rural America and requires the inclusion of telehealth as we move forward in restructuring healthcare as we know in rural America. Rural is not a small version of urban. It is a unique healthcare delivery environment. It's difficult to talk about rural these days because on one hand, you want to make sure that we share that rural is where innovation is happening in rural America. And that's because of the challenges that we face from workforce and resources forces innovation. Great concepts such as community health workers, patient navigators, dental health aides, all began in a rural context. And much of the true innovative approaches that we've seen in telehealth are as a result of trying to expand access and quality in a rural context. In addition to that, and I want to reference the prior panel that was up here as well too, now that as a nation we're finally tracking and measuring quality, we're able to break down some of the misconceptions that rural means a lower quality of care. Whether you're talking about CMS's star rating program, where we saw critical access hospitals that actually had the enough performance measures to report, we saw that they were ranked higher than some of the large teaching institutions that receive stars as well too. Even the Institute of Medicine highlighted the quality of care that can be provided in a rural context and the fact that rural providers are more inclined to collaborate, to network, to work together to improve rural health. Now, you talk about that, you talk about innovation, you talk about the innovative ways that telehealth is happening out there in the context of the fact that since 1990, while the life expectancy of individuals living in urban areas has increased, since 1990, life expectancy in rural America has decreased. Not raised as fast as rural, not stayed the same, decreased. And we're very pleased that the the CDC over the last year has finally taken a look at this and the drivers behind this. Obviously, the opioid crisis that we're seeing, suicides as well, too, both also mirror the fact that we have a tremendous shortage of behavioral health specialists in rural America. And right there, as we heard from the prior panel, a great opportunity to not just expand access, but hopefully change this dynamic of decreasing life expectancies that we are seeing in a rural context. Now, I mentioned that we're eagerly awaiting the introduction of the Save Rural Hospitals Act, which includes a telehealth component. The reason and the necessity for that particular legislation is since 2010, we've seen 78 communities lose their rural hospitals, 78 communities. At the National Rural Health Association, we've identified 670 rural hospitals at risk for closure in the next 10 years, 670. At the current rate, a quarter of the nation's rural hospitals will be closed within the next decade. Now, how do you continue to deliver care? How does rural health go ahead in an environment where you're potentially losing a quarter of all the nation's rural hospitals? The only way, the only path forward for rural health into the future involves the integration and expansion of telehealth within a rural community status and standpoint going ahead. So for us, the challenge is going to be, how do we highlight the great potential that the environment of rural has, at the same time identifying the significant challenges and the wrong path that we're currently on? Now, there was an election recently, as you may have noticed, and rural America did play a role in that election. Now, we always look at the bright side of things. The bright side of things is there is a renewed focus on rural America now, in particular on rural health. In the confirmation hearings of both Dr. Tom Price, the new Secretary of HHS, and the new CMS Administrator, Dr. Seema Verman, I'm sorry, not Dr. Seema Verman, both were asked about the context of rural health, and both indicated their support and interest in including a telehealth component to this going ahead. Now, although everyone I think is well aware of, hopefully, Seema Verma's interest in Medicaid reform going ahead, it's important to note that she does have a strong interest in rural health policy too. So I think the potential to actually see both a legislative and a regulatory approach to dealing with these issues in the future are extremely likely, and something that from an organizational standpoint we're very optimistic about as we move forward going ahead. So I do believe that we are fortunate enough to have some key congressional staff in the audience as well too today. And so I think I'm going to have a seat, and we can let our moderator begin the facilitation of the discussion on this, and hopefully we'll be able to hear their expert opinions on what they think from a legislative standpoint we will actually be seeing in the coming weeks and coming months on Capitol Hill. Thank you, Mario.
Thanks, Alan. I want to remind everybody that if you have specific questions, to put them into your app so that it will come up here and we'll be prepared to answer those questions. And we also have the microphones. I want to go back to Nate, to your presentation, because as I indicated, our analysis of the states within the MATRC region lag behind other states in terms of telehealth policy reform. You know, a lot of this is, you know, how do we go about doing that? What's the best process? What's the best strategy for doing it in a way that is objective, that looks at what's happening across the country, and that makes sense for those particular states? And I'm just wondering, from your perspective, for example, in Florida, we know in California, Hawaii, there's been strategies that have been coming from the governor. Can you talk a little bit about what's happening in Florida to provide kind of a guideline for how folks are going to be thinking about it here?
Sure. And first, Mario, I'd like to, on behalf of the state of Florida, apologize for lagging behind in your report.
Yeah.
So if you remember last year at MATRC, when I trash talked Maryland statute and compared it to Virginia's and whatnot. Told you about the telehealth bill that we helped draft for the state of Florida when we got into an intractable position on coverage. So it created Florida Telehealth Advisory Council under the Agency for Healthcare Administration. And that agency operates the Florida Medicaid program and all the facility licensure. So it was signed by the legislature, passed by the legislature, signed by the governor, created this council, 15 members. One is the Secretary of Medicaid, the other is the Surgeon General of the state of Florida, and then the others are members at large from hospitals and interested parties. They generated a survey that everyone had to answer when they renewed their licensure, every facility, every professional, every health plan, gathered that data, created a report to show what the actual marketplace reflected. Move all the BS and policy aside. This is what the real landscape is in Florida for telehealth coverage. And it was like every provider said it was, okay? They've had monthly meetings, half-day meetings, they're public meetings, and then the report is due in October with their recommendations and final findings. My hope is at the 2018 legislative session, it will serve as extrinsic evidence that the legislature can point to say this is why we need coverage in the state of Florida. We've heard from the payers for the last several years that they're covering it. This actual report shows it doesn't. And it should be a roadmap. I was talking with Neil from Maryland. This can be a roadmap for any other state that has a really crummy coverage law or no coverage law to focus all of your efforts into a single point of focus on your state level. I would recommend it.
Great. Yeah, just hold it. So on the federal side, I think one of the real paradoxes that we've seen is that for several years, I think last 5 years, we have seen bills introduced that have strong bipartisan support, even bicameral support, with partnerships across the Senate and the House. I know Representative Warner, Thompson from California, Warner from Mississippi, Senator Schatz from Hawaii. Others have been very active and committed to telehealth reform, particularly when it comes to Medicare and Medicare Advantage plans. And we kind of seem stuck. And we're living in a situation where we know there's going to be some changes to the Affordable Care Act. To what extent we don't know. And we also know that there will be some limitations in terms of Medicaid resources. So this is a compelling argument, I think, for states and the federal government to take a fresh look at telehealth, particularly in the context of value. One of the real, I think, bright spots in the Senate has been the Finance Committee and their Chronic Care Work Group, which has done a number of things, including being a real spearhead in terms of looking at telehealth legislation and this new bill that Alan referenced. Can you talk a little bit more about that, or?
Oh, absolutely. Well, obviously, one of the greatest barriers when it comes to passage of legislation has been what will the Congressional Budget Office score it as, the cost consideration. And that's been a significant barrier going ahead. But Mario, I'm going to take the opportunity, since we do have experts in the audience, congressional staff here at this time, I might ask if they would be able to come to the mic to talk about their ongoing work with this and where they specifically see this headed going ahead.
That would be fabulous. I mean, if we have the staffers here, if you don't mind coming up to the microphone and talking about the latest opportunities.
Give them a round of applause, everybody.
Senator Warner's staff, if you can introduce yourself and where you're from and
Hi, all. I'm with Senator Warner's office. Hello to my Virginians. And just my fellow congressional staffers just told me to say this as well, but all of our comments should be just off the record. I'm sure that's my comms director also emailed me, like, just in case. So in any case, I think speaking for the Finance Committee, which has jurisdiction over Medicare and Medicaid, I think there is an increasing recognition on both sides that value is where we're going to continue to see changes in the Medicare program in particular. And when it comes to telehealth and the use of technology, obviously Medicare is lagging a lot of state Medicaid programs, particularly ours in the Commonwealth, for example. I think that with regard to the chronic care legislation, so for those of you who aren't familiar with that, our office actually had the opportunity to do some significant work with that. That was a 2-year-long process that began at the beginning of the last Congress, led by Chairman Hatch, Ranking Member Wyden, Senator Isaacson, and my boss, Senator Warner. And ultimately, after this process of compiling feedback, we came together around 15 sort of consensus, bend the cost curve, triple aim type Medicare policies. 4 of those had to do with telehealth. And so, which really just goes to show the extent to which there is enthusiasm around this. There is sort of an understanding that this is where we're going to be changing the program in the coming years. And I think one thing we always talk about in Congress is what is the vehicle? That is, members of Congress don't like to vote very much, and as a result, things get together, compiled together in big bills. And I think that the Chronic Care Act that we introduced at the end of the last Congress, after that extensive process, that's a very likely potential vehicle, and I think we're going to see some real action on that this year. We're very hopeful. So.
I also see Amy Grace from Senator Schatz's office here. Can you talk specifically about the bill and the process and what we can expect? Also, you're involved with the ECHO Act, and there's a question from the audience related to the ECHO Act and its impact on telehealth. If you could cover that as well.
Sure, yeah, thanks so much, and it's really an honor to be here with all of you. My name is Amy Grace. I'm a pediatrician by background and also the health policy advisor for U.S. Senator Brian Schatz from Hawaii. He's the lead sponsor of the Connect for Health Act that would lift a lot of these outdated restrictions on Medicare reimbursement of telehealth. And we've had the great honor of working with our colleagues from across the aisle and both from the House and Senate on working on this bill. So there really is a ton of interest in Congress on telehealth. We just have to figure out how to get it done, which is where we've really appreciated so many of you and your help in this. So just to give you a background on how the Connect for Health Act came to be, Senator Schatz, and my comments are also off the record, just to say that too. So Senator Schatz is the ranking member, so the top Democrat, on the Telecommunications Subcommittee of the Commerce Committee. And there was a hearing almost exactly 2 years ago now on telehealth. And Chairman Wicker of that subcommittee also is very interested in telehealth. And through that process, we came to develop a working group that ended up being 6 different Senate offices. So Senator Schatz, Senator Wicker, Senator Cochran, Senator Warner, Senator Thune, and Senator Cardin. So really across the US and very bipartisan. And we really could all come together around this goal of reimbursement. So we saw that, we hear a lot of different concerns, right? We've been talking about a lot of them in terms of telehealth and what are the barriers to adoption. But could you raise your hand if reimbursement is an issue for you? That's what we hear. So that's why we're working so much on that. And, in general, folks say, where goes Medicare, there goes everybody else. And we've seen a little bit different from that in the telehealth space, but we still think that there's a real role to try to change Medicare's outdated rules, such as the restrictions in Section 1834M of the Social Security Act that limit a lot of where the reimbursement can come from in terms of telehealth. So our group came together to try to lift those restrictions. I think Elizabeth can talk to this more from some of our appropriations and budget side, but we have been under this issue with the Congressional Budget Office, which is a bunch of economists and analysts that look at different sorts of legislation and try to predict what it's going to do to the federal budget over the next 10 years. And telehealth, while a lot of us know it improves outcomes, it saves money, it can also increase access and increase utilization if restrictions are lifted, or at least that's the belief. And so they have a view that any sort of legislation that gets rid of restrictions will increase access and utilization and therefore increase costs. So our goal in introducing the Connect for Health Act was to lift a lot of the outdated restrictions, but do so in ways that expose Medicare to less financial risk. So for example, if you look at Medicare Advantage, which has a more set payment to it, or global or bundled payments, or accountable care organizations, particularly two-sided risk ACOs. Those are areas where we think that maybe we would have a little more luck in terms of getting CBO to see the value of telehealth and really seeing telehealth as just another tool in the toolbox for folks to use. So after about 6 months and tons of wonderful feedback from a lot of different groups, probably a lot of you, we introduced the Connect for Health Act last Congress. We were so thrilled to get 4 of the provisions with revisions into the Senate Finance Committee's chronic care package, and we're very much looking forward to that moving forward. We ended up having 18 co-sponsors in the Senate, 32 in the House, and 98 endorsing organizations, national organizations. So there's really a ton of interest on this from a lot of different sources. We are gearing up right now to reintroduce the bill. So if you want to get in touch with us or you have a national organization, please encourage them to get in touch with us. We are going to be looking at a lot of similar provisions as last year and also some new ones because we're trying to be as creative as possible in terms of lifting these restrictions, but also, again, being sensitive to the budgetary concerns. And just wanted to mention on the ECHO Act, that was introduced by Senators Hatch and Schatz last Congress. It directs the Secretary of HHS to do a study about the Project ECHO model. Do a lot of you know about the Project ECHO model? Yeah, really amazing. For those who don't know, it's a continuing medical education model that uses video teleconferencing to connect specialists at academic hubs with primary care providers in rural and underserved areas. And it really is based at the University of New Mexico. It has amazing promise, but we're looking forward to more data, and that should be coming out within 2 years. So I'm very much excited about that. Just to hit on one other question, the good resource, I want to put in a plug for Mario's organization, the Center for Connected Health Policy, always sending out really timely updates on various telehealth legislation. Thank you.
Thank you, Amy. And if anybody's interested in being on our newsletter, we send out regular updates on policy and information. Just go to our website and you can sign up. You mentioned the CBO, the Congressional Budget Office, which is an enigma to me because I look at a program like, for example, Dr. Lowry's Angels program that not only saves lives, but ultimately saves money to the state of Arkansas to the extent that their Medicaid program recognizes and is part of it. If he would have started that program and had it evaluated as to whether it was going to save money up front, it never would have gotten off the ground. Yet here we have a dilemma with the Congressional Budget Office that doesn't look at issues related to cost avoidance, cost to the consumer, long-term benefits related to prevention and early intervention, all these factors that we consider to be critical. I know the CTEL, which is the Center for Technology e-Law, has been very aggressive and active in working with them to help the committees to raise the evidence. So if you have evidence of cost savings, by all means, channel them to the committee. But Elizabeth, could you talk a little bit about the CBO specifically?
Sure. Thank you, Mario. I'm Elizabeth Joseph. I'm Senator Cochran of Mississippi's Health Policy Fellow on loan from the University of Mississippi Medical Center Center for Telehealth. And so I think some of you may have heard my colleague Tiersany Davis yesterday speak here as well. So it's an honor to be here, and also want to reiterate off the record. So I think Amy and Mario both have well articulated the CBO challenge, and that is kind of the roadblock that we have for really advancing telehealth legislation. So I think a good way that Amy has explained it, and that I find is an easy way to understand it, is CBO views telehealth as an additional service in the Medicare program, whereas state Medicaid programs see it as a different way to deliver care. It's a different modality for delivering health care to beneficiaries. So anytime a new service is added, CBO would see that as an increased cost. Relatedly, CBO also questions if telehealth services would substitute for in-person services or just be another additional way to access service. So the question of supplementing versus supplanting services. So increasing access to care without the certainty of what it would do for utilization in the long run is perhaps an impact to cost in their view of things. So we talk about data. In 2014, the CMS reimbursed in the Medicare program for telehealth services $14 million. And so I think we all know that that's pretty much nothing. And so there's not a lot of data out there about how telehealth would impact Medicare. And so CBO has said in the absence of Medicare data for telehealth, it will accept outside sources. But I think there's questions around, from CBO's perspective, how so many of these studies would translate into a fee-for-service Medicare world. So that's kind of where we are with it. There are a number of efforts, as Mario mentioned, the CTEL and ARC is now working on a new study around telehealth and the cost and cost effectiveness of telehealth services. So there's a number of ongoing efforts around data and showing how this impacts healthcare outcomes and cost. So continue to stay in touch with us. The policies are, we're working on policies to address these challenges, and really appreciate your ongoing input and support of what we do.
Thank you. There's a question related to the federally qualified health centers and rural health centers and the limitations that they have related to the distance site and their arcane language related to the use of telehealth. I don't know whether Nate or Alan, do you have any insights on what we can expect in terms of changes there or some of the issues that you may be hearing about? Amy, of course, yes.
Our bill does address that. The original Connect for Health Act did address the distance site issue, and we're currently working on the originating site issue. Thank you so much. Sorry, just to say again, the original Connect for Health Act did have a provision about federally qualified health centers and the distance site issue that a lot of you are bringing up. What we were hearing from NAC, the national organization, is that there is a need for, even though FQHCs are listed as originating sites, there's still the other 1834M restrictions in terms of rural limitations. And so those are things that we are looking to include in this next draft of the Connect for Health Act.
Yeah, I think that one of the, I guess, dilemmas that we see across the country in terms of the uptake of telehealth has been that rural clinics and federally qualified health centers, by the very nature in which cost-based reimbursement is determined, is a counter-incentive to the use of telehealth. So they really have been the last of the party in terms of utilizing these resources, everything from live video to store and forward and remote monitoring, care coordination, patient portals, teleconsultation, all of these above and beyond just the diagnostic and treatment resources that can be utilized. And so I think this is going to be an area of real focus, not only with legislation, but also hopefully with the changes in CMS and with the Bureau of Primary Care, to recognize that community health centers, particularly in rural areas, are the only source of care for primary care and support in those communities, and should be encouraging the use of telehealth through those efforts. Okay, we have a question here for you, Alan, related to the rural hospitals. If you want to read that and respond.
Yeah, absolutely. Another attractive care. Well, you all can read it. It's right up on the screen for you. I can skip that and just go to the answer. Absolutely. I don't think most people realize that more than half of the nation's rural population currently lives in states that have not expanded Medicaid. Just think about that for a second. More than half live in states that have not expanded Medicaid. And one of the grand compromises of the Affordable Care Act was the reduction of disproportionate share payments, because as we knew, all states were going to expand Medicaid. Well, we got the DSH cuts going in, but we did not get the Medicaid expansion. And overlaying a map of those states that have not expanded Medicaid with the states with the hospital closures to date, and you see what that really means. But those states also have high rate of obesity, diabetes, hypertension, a disproportionate share of the opioid deaths as well too. You can use one map for every health disparity and with the closures of hospitals as well. But to this question, it is important to note that nationally, rural hospitals, the cost to Medicare beneficiaries is lower than urban facilities. And that's been part of the argument that we've tried to make on Capitol Hill. Closing a rural hospital does not save cost. The patients still need to seek health care. They go to large urban institutes. They incur a cost in the travel cost, and once they get there, the cost of the Medicare program increases as well too. So this is one of these unusual situations from a policy perspective. If you are an ardent conservative member of Congress that wants to reduce government spending, you want to do everything you can to keep these rural hospitals open because that's how you drive down costs. And I think that's an important point to be made. With the inclusion of a telehealth option as we move forward, again, you get to the option of what a lot of the state Medicaid directors see is this is a different way of delivering health care, a cost-effective way, and an ability to keep the doors open.
Yeah, and I think we've learned over the years that interventions such as tele-ICU, tele-stroke, tele-ED, all these efforts in which you can connect a major medical center to a rural hospital where that rural hospital doesn't need to hire that intensivist, doesn't need to have all of the bells and whistles of a major medical center and still be a viable institution for that particular rural community. And so not just the services that they provide in terms of being a center for healthcare, but also being a receptor to allow for these technologies to totally flourish. Any questions from the audience? You want to come up to the microphones at all? Are we good on the policy side?
How many people have a virtual ICU? How many people do that? Yeah, there's been a number of cost studies trying to show the benefit, cost savings, short or long term on telehealth, and it's a challenge because it's an overlay of a whole bunch of different ways of providing care, so it's hard to just say this only telehealth did everything, right? Because you make operational changes. The one set of studies that I've seen, though, that really were able to target it was the virtual ICU. Yes, it's a commitment, but all of those hospitals that I've seen have significant cost savings, notwithstanding the fact they're paying for it. Reductions in avoidable readmissions, increases in patient satisfaction and quality. And I liken it this way. If any of you have seen these or gone out to Missouri, for example, to see Mercy Virtual's center, imagine playing football or just watching a football game where there were no quarterbacks. People just like, okay, go. Let's all just run our own patterns. The efficiency and the coordination that you can have with like a doctor or a practitioner, quarterbacking your ICU, the reduction in beeper fatigue, all these things pay off huge dividends on your care.
Yeah, you mentioned Mercy Virtual. If you're not familiar with that particular site, I'd encourage you to Google just Mercy Virtual. It's the first hospital in the country that's been built without beds. A total virtual care center, hospital that was destroyed by a tornado several years ago, and they had the foresight to think about what would healthcare look like in the future. And they serve multiple states. And they do everything from routine care to things like tele-ICU. And I think that really is where we're headed in the future, putting the patient, the consumer at the center of the healthcare delivery system to the extent that we can break down those walls, rethink how care can be delivered in the most efficient, quality method possible that meets the triple aim. I don't want to lose this opportunity by having these key staffers here who are really our champions in Congress and their bosses as champions in Congress. We have some real obstacles. The CBO certainly being one of them, politics being another, but I think this is one of those opportunities where I really believe that there is bipartisan strong support across both houses and the Senate, and the House, to get something done this year. And they hear from the ATA all the time. That's the lead trade organization that we all know of that is really advocating on behalf of telehealth and telemedicine. They hear from the commercial vendors and their lobbyists. They hear from the insurers. They don't hear that much from the consumers and consumer organizations because there's still a disconnect between, say, an organization that's advocating for reductions in poverty or greater health access and understanding that their agenda is the telehealth agenda and that needs to be considered in the same context. So to the extent that you're involved with any consumer organizations, consumer advocacy groups, I think those are the kinds of organizations that would be really strong in terms of contacting your senators and your representatives that you want to see some change done. Because I really do believe that this stalemate that we're seeing across the states, yes, we're seeing incremental changes slowly but surely, but I think once we see Medicare and not only transforming Medicare to be more value-based and using telehealth, but amendments to the Social Security Act, that will give more confidence to policymakers on a national level and across our states to be more encouraged, I think, to take on these laws and regulations. If any of you from the states here in MATRC are interested in support and assistance on model legislation from other states or policy briefs, by all means, please contact us. That's what we do. I also want to make a plug for us as an organization as part of a new movement of national telehealth resource centers around the country. We have been funded for 5 years. There have been some of these organizations that have been funded for over 10 years, 12 years. This past year, we decided that we're stronger together in terms of the resources and the synergy that we can bring by being in every state, providing technical assistance and support. If you really like the work that MATRC has done, think about how that could be multiplied by having the resources of all the telehealth resource centers in the country to come to bear to provide support. And so we have joined together as a consortium, the National Telehealth Resource Consortium, to work together and be able to mobilize and assist in every way possible. So if there's a question out there that you have related to telehealth, no matter how crazy it may sound, we have somebody in that consortium that can answer it. And so with that, any final words from our panelists?
I would just add, when it comes to rural policy, telehealth, also put another resource out there. Just remember rural health. Google, Yahoo, Bing, the words rural health. Our website's always the first thing that comes up. We've got policy documents there, resources, and we too can keep you updated on what the legislation is going through as it relates to rural.
Great. Nate, you have any final words?
No, thanks. You've been great.
Yeah. All right. Thank you all for your attention, and thank you for our congressional staffers for making the trip. Kathy?